Hello and welcome to the Foundation Medicine Foundation Frontiers Medical Education webinar series. We have an exciting late-breaking addition to our series today to talk about a new drug that has been approved for hormone receptor positive metastatic breast cancer with Foundation Medicine as the companion diagnostic. My name is Mia Levy, and I'm the Chief Medical Officer of Foundation Medicine. I'm a practicing breast medical oncologist, and I'm incredibly excited to share with you today topics for which I am incredibly passionate. And as an employee of Foundation Medicine, here are my disclosures. 70% of patients who have metastatic breast cancer have a specific subtype called hormone receptor positive HER2 negative. It drives our decisions for which types of therapies to use, and in particular, this patient population benefits from hormone therapies. The current standard of care for the treatment of hormone receptor positive breast cancer includes the treatment with serial hormone therapies, followed by chemotherapy or other targeted treatments. Since the last several years, there have been new targeted therapies that have been approved for the use in hormone receptor positive metastatic breast cancer. Standard first-line therapy is a hormone therapy plus a CDK4/6 inhibitor, HT standing for hormone therapy. In the past, we would then move on to second-line therapy and consider, if the patient had a mutation in the PIK3CA gene, the use of a medication called alpelisib, a PIK3CA inhibitor. The recent approvals have resulted in some exciting changes that are bringing targeted therapy into the first-line setting for hormone receptor positive breast cancer. In particular, capivasertib was recently approved with hormone therapy in the first or second-line setting for patients who have had a PIK3CA AKT or PTEN alteration. Capivasertib is a type of AKT inhibitor. It is appropriate to use this medication in the first-line setting for patients who have progressed while they were on adjuvant hormone therapy or within a year of completing adjuvant hormone therapy. Elacestrant is a novel oral medication that is used in patients who have acquired alterations in the ESR1 gene and is used in the second or third line setting in hormone receptor positive metastatic breast cancer. This October, we have seen the approval of a new medication, a new PIK3CA inhibitor called inavolisib, in the first line setting for this patient population who is at higher risk for being resistant to endocrine therapy. Again, patients who have recurred while they were on hormone therapy or within a year of completing it. And inavolisib is used in combination with hormone therapy and a CDK4/6 inhibitor. This now squarely moves comprehensive genomic profiling into the first-line setting to help drive first-line treatment decisions for this patient population. In addition to the use of comprehensive genomic profiling at the time of disease progression to look for acquired alterations in the ESR1 gene and potential eligibility for elacestrant. This now makes us think about the population of first-line metastatic treatment for hormone receptor positive disease into slightly different subsets. So we now have those patients who were diagnosed with de novo metastatic breast cancer, meaning that they had stage 4 disease at the time of their diagnosis, versus those who have recurrent metastatic breast cancer, where they previously had an early stage breast cancer for which they were receiving curative treatment, and now they have a metastatic recurrence. Amongst those patients with recurrent metastatic disease, those who have recurred while they were on adjuvant hormone therapy or shortly after completing adjuvant therapy have a higher risk of being resistant to endocrine therapy than those who have recurred more than a year after completing endocrine therapy. And that is why this medication was developed specifically for this higher risk population with PIK3CA mutations. These PIK3CA mutations may make them more resistant to endocrine therapy alone. The INAVO120 clinical trial randomized patients who had hormone receptor positive HER2 negative breast cancer with a PIK3CA mutation to either receive standard of care endocrine therapy with a CDK4/6 inhibitor with or without inavolisib in a phase 3 randomized placebo-controlled clinical trial. One of the things that's important to look at with respect to the results is that the population of patients who received the placebo medication had a median progression-free survival of 7 months. This is a lot shorter than your standard overall population of patients who receive a CDK4/6 inhibitor and endocrine therapy in the first-line setting, where historically we've seen responses of a median progression of 18 months in that population. So this population who has PIK3CA mutations, they are progressing more quickly on the standard of care treatment. And thus the addition of an inavolisib to their treatment regimen resulted in a progression-free survival of 15 months, which is a significant benefit for these patients, bringing them closer to what the standard of care looks like for the rest of the patient population. I am very pleased to say that Foundation Medicine is the only FDA-approved assay for the companion diagnostic for both inavolisib as well as capivasertib and alpelisib, making Foundation Medicine's tissue and liquid tests the choice for comprehensive genomic profiling in the first-line setting for metastatic breast cancer patients. And these alterations are not rare. Over 60% of patients will have at least one of these genomic alterations when tested in the first-line setting. AKT mutations are 5 to 6%, PIK3CA mutations 40%, PTEN alterations are 10% divided between mutations and losses, and ESR1 mutations can even occur in the first-line setting up to 8% of cases. And these actionable alterations do increase over time, largely in part to the emergence of ESR1 mutations over time. The important thing to see here is that at baseline, prior to the start of first-line therapy, we can find these alterations at about 60% in our tissue specimens and about 43% in our liquid specimens. So why the discrepancy? It's important to understand the nature of a tumor shed into the circulation and our ability to detect these on liquid biopsy tests. So when we think about how we do our testing for metastatic breast cancer, we first need to think about which type of specimen we're going to use, either a tissue specimen or a liquid specimen. The timing of the testing, do you do that right at the time of initial diagnosis or later, or both? And which specific alterations are you looking for, and how does that inform your decision-making for these two questions? With respect to the tissue specimen, it's often available at the time of a metastatic diagnosis for metastatic breast cancer. Patients will often get a confirmatory biopsy to determine if their tumors are still hormone receptor positive, to actually confirm it is in fact metastatic breast cancer. So tissue is often available. Often it's a bone lesion, and there's a misconception that bone lesions don't have good results for comprehensive genomic profiling. They actually do. With our modern approaches to processing those bone specimens, we get great yield for comprehensive genomic profiling for those specific specimens. Liquid biopsies, on the other hand, can have low shed in metastatic breast cancer, so you have to take that into account. We'll talk about that a little bit more. But liquid biopsies do have a faster turnaround time. You simply collect the specimen, can even be mobile phlebotomy, and the turnaround time is about 7 days, which can accelerate decision-making, especially when you need to make it in the first-line setting now. But tissue testing, on the flip side, can be more sensitive for detecting some types of alterations, including PTEN loss, for which you need a higher amount of tumor purity, easier to get on a tissue specimen than on a liquid biopsy, which may have low shed. Foundation Medicine's ctDNA tumor fraction is a novel complex biomarker that helps us estimate the amount of circulating tumor DNA in a specimen. There's a number of factors that can contribute to whether or not a specimen has high or low shed, including how aggressive is the tumor with cellular turnover. Many metastatic breast cancer patients have indolent disease that isn't turning over very quickly, and as a result can have low shed. You also have a consideration for the amount of burden of disease that the patient has. So if you have a single bone metastasis or two, you may have low shed as well. Whereas if you had many metastases, you may have a higher amount of shed. And at treatment progression, we often see the disease burden increasing, and as a result, the tumor shed increasing as well. With hormone receptor positive metastatic breast cancer, we look at this measure of how much shed is there as being a threshold of a tumor fraction greater than or or equal to 1%. And over multiple lines of hormone therapy, we see that the tumor shed does go up with progression from about 40% to about 50% at the time of disease progression in the second or third line setting. But this limitation of these tumors having low shed does make some limitations for the use of liquid biopsy testing in the first line setting for hormone receptor positive breast cancer. So if we look at a population of about 100 patients, we would see that if you're getting a liquid biopsy at the time of metastatic diagnosis prior to the start of first-line therapy, about 40% of those patients will have one of these mutations in PIK3CA, AKT, or PTEN on a liquid biopsy. The rest of the 60% may be a combination of being truly negative versus just having low tumor shed. So those who have a high circulating tumor DNA are more likely to really be negative. But those who have a low circulating tumor DNA, which is 40% of patients, we would consider that an indeterminate negative and really consider tissue testing. So if you were to reflex to tissue testing at that point, you would find another 15 patients with one of these alterations, which is a pretty significant increase in the number of patients you would identify. Similarly, if you were to even look at tissue testing for the patients who have a high tumor fraction, you would find 1 out of the 20 would still have one of these mutations. And that's in large part due to the high prevalence of PTEN mutations, but the need to have a high tumor purity in order to detect those deletions. So let's put it all together. This case of mine, I was surprised that right as this drug is being approved, I have a patient who is really appropriate for it. She's a 61-year-old woman who had initially been diagnosed with stage 1 breast cancer, had her breast surgery, and was put on adjuvant hormone therapy. She didn't really tolerate the adjuvant hormone therapy well, and she discontinued it after a few months. And within a year, she had a regional recurrence of her hormone receptor positive disease, again re-resected, and this time she went on a different hormone therapy and was able to tolerate it. But unfortunately, within 14 months, she presented with back pain, and a CT scan and a bone scan showed that she had widely metastatic bone disease within that short period of time. So as I was scheduling her for a bone biopsy with our interventional radiology service, I ordered a liquid biopsy comprehensive genomic profiling to be able to start the process of determining which driver alterations she might have had that was contributing to her rapid progression and resistance to hormone therapy. So as we think about the treatments for this patient, if she has a PIK3CA mutation, she may be eligible for a combination of hormone therapy with a CDK4/6 inhibitor, which she had never received, and inavolisib. Versus if she had a PIK3CA, AKT, or PTEN alteration, she may benefit from hormone therapy and capivasertib. And if she doesn't have any of these alterations, I would just put her on hormone therapy and a CDK4/6 inhibitor. And again, acknowledging that I'm still going to be collecting a tissue specimen and can use that specimen if the liquid biopsy is negative, especially if I don't find something, I would be looking for PTEN alterations in that tissue specimen. And understanding that the liquid biopsy, however, is going to have a shorter turnaround time. And I was able to order it and draw the specimen and get the results even before her tissue biopsy had even been conducted with interventional radiology. So the disadvantage of that could be that I may get a negative result and I still have to order the tissue test. Well, it turns out that she did have a high tumor fraction and a PIK3CA mutation was detected, which may be the reason why she has progressed so quickly on the hormone therapy. And we are looking to acquire this medication for the inavolisib to add to her hormone therapy and CDK4/6 inhibitor in the first line setting with the hope that we can keep her on hormone therapy and not have to go directly to chemo. So as we're making our considerations for CGP testing in metastatic breast cancer, we think about the sensitivity of each of these approaches with tissue and liquid, understanding that a higher amount of tumor purity will give us better sensitivity, and we may need to use tissue as a result, especially if those patients have a low tumor fraction. but that liquid biopsy has a much more rapid turnaround time. We do find many, many patients who will have one of these alterations, 40%, and that can inform our first-line treatment decision. So the timing now into the first-line setting and as soon as possible at the time of metastatic diagnosis becomes even more imperative. And understanding that just because you have a low tumor fraction at the time of metastatic diagnosis doesn't mean that you can't use liquid biopsy testing in the future, because tumor fraction does go up over time. So as a patient's disease progresses, you can consider using liquid biopsy to look for ESR1 mutations in that setting. I want to thank you all for your time and these exciting new updates for the treatment of metastatic breast cancer. Thank you.